And then we can stop.
And can
Did Sherry here and immediately?
I think Sherry did.
That was perfect timing. Thank you, Sherry.
My pleasure.
Okay. We have a very good collaborator of ours and friend visiting, and so I'm really excited about that. It's only the second time I've gotten to see him in person after probably dozens or hundreds of Zoom and phone calls, so this is great. But so Dr. Tandon is a physician scientist and healthcare innovator who serves as the Director of Cardiovascular Innovation at Cleveland Clinic Children's and the Clinical Innovation Lead for the Pediatric Institute. And we've been working together on a number of projects. And he's kind of, if you want to know about wearables and technology for pediatric cardiology, he's kind of a resource that anybody would go to for that, which is actually how we first met at this meeting where we kind of came together and started talking. And so I'll let him take it from here, and we'd love to hear about your work.
Sure. And I'm hoping that people on the web can and hear, right, Sherry? People can hear and
Yes.
okay, perfect. And then feel free to interrupt whenever you want. This is not a lecture. So thanks, Omar, for introducing me. And I'll be talking about kind of harnessing technology. And these are my disclosures, including this company that's trying to make a wearable pulse ox for babies. So just because that might be relevant to what we talk about. And last night, Omar asked me, what are the key unsolved questions in congenital heart disease? And I think I wanted to just set the context for you guys about why it's a little harder to answer some of the questions for kids with congenital heart disease. Thankfully, right, there's been lots of progress in surgical techniques in the last 40 years. And so, you know, other than the super highest risky patients, most of them survive, right, short term. And so now what we're trying to figure out is, for the people who have short-term risk, how do we mitigate that risk? And then in the long term, like years, decades, what do we need to measure for them, right? Like, how do we prognosticate for them? How do we intervene at the right time? And, you know, there's a lot of talk about precision medicine and, you know, personalized medicine, but we've been doing that forever, right? It only became a catchphrase in adult cardiology like a decade ago, but every kid has subtly different anatomic differences. Every kid has, you know, a different surgeon who did a slightly different surgery. And so we always have to kind of consider what's the right intervention for that patient at that time, right? Like, do we just leave them alone? Do we do another surgery? Do we start medications? And so we're always trying to figure out, like, yeah, there's a given guideline for a population, but for that particular patient, what should we be doing then? And so, you know, I want to talk about how I think about a biomarker. Obviously, the FDA and others have a separate definition of biomarker, but to me, right, it's a signal, whatever that signal might be, and it defines disease severity, or it can predict prognosis or response. And ideally, those biomarkers would be easy to obtain, which, you know, I'm hoping are generally non-invasive, cheap, and then, right, they need to be sensitive and specific. Okay, my mouse goes on, right. And then, you know, we get a lot of vital signs, or we get a lot of biomarkers when we meet a patient, right? We get vital signs from them. We can do a cardiac MRI and look at right ventricular size. We can do lab tests and get lactate. We can do a physical exam, right? Actually touch the patient and listen to their heart murmur. We can get digital biomarkers like heart rate variability, right? And so these are all, to me, just different forms of information, biomarkers that we need to put together in some way that's meaningful for the patient. And, you know, I've been trying to think about how I put all my research together, because my bosses are like, oh, you're doing too many things. But I've been trying to think about it just as a cycle, right? We have to identify what signal we need. We need to figure out how to acquire that signal. And so, you know, my work centers on either imaging work or wearable biosensors. We have to figure out how to interpret that, right? So that's where either regular statistics or AI and machine learning come in, right? Like, what does this mean for the patient? We need to implement that, right, in clinical practice. Like, how do you scale it? We need to validate that it actually does something that's useful for us. Then, when you're talking about getting it to market and having it actually be effective in patient care, right? Has to be some scalable solution, right? Can't be $1 million for, 30 minutes of information or something like that. And then once you implement it in the real world, right, then you can revise, oh, does that signal actually help at a big scale? Perhaps we can get less data, right? And with the same clinical impact. So I'll talk about these things. So starting with the imaging work. So I'm going to walk you through tetralogy of Fallot, which is a pretty common form of congenital heart disease. And in this disease, which is about 1 in 3,500 babies, what's called this outlet septum. There's a bunch of muscle that splits the aorta from the pulmonary artery that develops in an abnormal spot. So it comes kind of more anterior forward in the baby. And what that does is that it creates this hole in the ventricular septum because the two parts of the septum are supposed to align, like they're supposed to grow like this, and it doesn't grow like that. And so you get a hole called a VSD, ventricular septal defect. And because the pulmonary artery in 3D space is anterior, if that muscle comes anterior, it makes the pulmonary artery small. And so the pulmonary artery becomes small, and that makes right ventricular hypertrophy because it has to pump through this obstruction. And then the aorta comes anterior, and those are the 4 things. But we think that they're all related to this one developmental abnormality where this muscle just ends up in the wrong spot. And so over time, generally around 6 months is when we do the first surgery for these babies. And we put a patch across the right ventricular outflow tract and we close the hole, right? These are the 2 things that we do to fix the heart disease. But there's a lot of technique variation, and there's been some back and forth in the literature about what's the right way to do it. And so if you put a small patch in, you could leave some theoretical right ventricular outflow tract obstruction. And that can make the right ventricle over time become thick, just like if you work out a lot, right? You're pushing against a lot of resistance, you get bulkier. The right ventricle gets bulkier if it's pushing against this obstruction for years and years. If you make the valve, the cut that you make and the repair too big and the pulmonary valve becomes leaky, then the right ventricle tends to dilate over time because for each liter that it's pushing out, half a liter goes backwards and then has to pump 1.5 liters and it gets dilated. And you can have both, right? You can have both a leaky valve and a tight valve. So as I said, for this disease, yeah. So the pulmonary valve annulus, right? The piece of tissue that anchors the valve leaflets is usually too small. And so sometimes you have to cut across that ring of tissue to make the hole big enough that there won't be residual outflow tract obstruction. And when you cut the annulus, the leaflets don't work anymore. So sometimes the surgeons decide to make a fake leaflet, but it only lasts like a year. And so then every time the right ventricle pumps, it pumps out, right? The job of the valves in the heart is to let blood through without obstruction and then not let it leak backwards. But if you have to cut the annulus, they often end up leaky. And so when they're leaky, for each 1 liter that you're trying to get to the lungs, you have to pump 1.5 liters because half a liter or whatever, right? I'm making up numbers, but like if 50% of it leaks back, then you have to pump 1.5 times more, and that leads to chronic dilation over time.
What's the diameter of the vessel?
Like in babies, like in the 1 to 2 centimeter range. The pulmonary artery, yeah. So the surgeon, I mean, I'm not a surgeon, but the surgeons do some crazy stuff to these babies.
While speeding.
Yeah, well, usually we have to put them on bypass, but yeah. So for this surgery, but they do other surgeries off bypass, yeah. And we usually wait to 6 months to do this because we want the babies to grow. They're usually like double the size at 6 months than they are, so technically easier to do the surgery. But and sometimes we have to do temporary stuff, like if they're not big enough, then we have to put in a shunt to get blood to the lungs. right? We sometimes have to do temporary things to tide them over till when they're big enough to do this surgery. And as I said, the survival is actually generally pretty good, right? So this is years after follow-up in this JAMA Network Open paper. The valve sparing surgeries, they tend to do very well. So this is people who end up without a leaky valve or not as leaky a valve. And then this transannular patch group has significantly worse mortality over time, right? But look, you're talking about 30 years, right? Even at 30 years, 90% of them are alive, which is great, right? This is a good problem to have that they're surviving. But it means, right, what do we need to understand about them that's gonna, what do we do at 6 months? How is that gonna affect what they're like at age 10 or 20 or 30? It's a complicated question that's hard to study. And then in terms of interventions, that this is any intervention. So the transannular patch people have more interventions. And then in terms of a new pulmonary valve, right? So this is what we can do for people. If the pulmonary valve is too tight or too leaky, we can give them a new valve, either transcatheter or by catheter intervention or by surgery. And the transcatheter, transannular patch people with the leakiest valves tend to get that sooner. To be honest, that's probably a little biased because that's what we think we ought to be doing. So we do it because the valve is leaky. So right, like for this population, let's say, what we're trying to figure out is who's going to die early, and more importantly, like why and what can we do about that? When do they need a new competent pulmonary valve? And does getting a new pulmonary valve actually decrease mortality or improve quality of life? We don't actually know that it improves mortality. As you can imagine, doing a study that tests like, oh, what are they going to be like in 40 years, right, is a hard study to run. So what we're trying to do, right, is identify some marker of ventricular health, let's say, and say, okay, well, what we know that if we don't do anything forever, right, and the right ventricle gets foggy, gets dilated, and it gets thick, they do have early mortality compared to a general age-matched cohort. And so if you, let's say there's some irreversible damage threshold, right? The right ventricle gets too big, affects the septal motion, and the left ventricle starts failing. And this is like the end game of tetralogy if you don't do anything for them. So if you do a pulmonary valve replacement too late, maybe they don't recover enough and then they pass away earlier than they ought to. The problem with doing pulmonary valve too early is if they're like a pulmonary valve replacement is if they're too young, then you can't put an adult size valve in. So you're signing them up for another surgery earlier. And then any valve replacement, whether it's with homograph or surgical or whatever, the valves tend to last a median of 10 years. So if you do it 5 years early, and then you do the next one 5 years early, then you've signed them up for an extra surgery over their lifetime or extra intervention. So what we want to find is this optimal threshold, right? You get them right close to the edge, and then you do it, and it's as long as you can wait without waiting too long, right? Price is Right rules. You want to go right up to the edge without going over. But we don't know what this marker is, right? So my K23 project right now is to take cardiac MRI data from retrospective data sets. And cardiac MRI is a standard way that we image these patients because that is the most quantitative way of figuring out the right ventricular and left ventricular size and function. And those are some of the metrics that we use to decide right now when we should do a valve. And we're trying to say, okay, in these two large data sets, which we have access to, what are the shape and motion characteristics, and I'll talk about that in a minute, that predict death, ventricular tachycardia, and ventricular fibrillation as our composite outcome. And then in the prospective part of this study, what we're trying to do is say, okay, patient gets a standard clinical MRI. If they have a dilated right ventricle or low ejection fraction, we give them a new valve, right? And then what we want to do for research is we say, okay, at 1 year follow-up, did they respond or not appropriately? Did the left ventricle become normal size? Did the right ventricle become normal size? And then can we see differences in this pre-MRI to say, can we predict better who's going to respond or not? Because actually right now, 30 to 40% of people don't respond appropriately. Their RV still is boggy, or their ejection fraction still abnormal. And what that makes us think is that maybe we waited too late for that kid, right, or that young adult to get a new valve. Or there's some other thing about it that we're just completely wrong about, right? Like maybe these metrics aren't the right metrics that we should be using. So, we're working with some colleagues in Germany to basically, like this is called voxel morph. It's like one of the face, if you see like faces morphing from one to another, we're trying to use that through the cardiac cycle to generate a vector field, break this vector field down with an autoencoder encoder decoder and say, hey, can we reduce the dimensionality of this vector field to say, like, can we identify different features? Now, like, what are we going to do about that in the long run? Like, how do we tell the surgeons to do a different surgery? That's really the key question, but we're starting with what we can control at the moment. And then we're trying to use some kinematic approaches to break down the motion of the ventricle through the cardiac cycle. And then we are looking at the shape of the ventricle. So we've created a ventricular shape atlas, and we're trying our prelim data. Actually, I should update this slide because we got a paper published about this now. That shows that like the RV apex pointing in the wrong direction is a reasonable indicator of bad events. Again, how do we fix that is the real question, right? Like, what does that mean? What should we be doing differently for these patients? That's the next step of understanding what this means. But I think all of you can imagine that a one-time MRI is probably not enough information for these patients. And it's not all the clinical information that we get for these patients anyway. So usually what we do is an annual echo, like ultrasound or cardiac MRI. We get an annual EKG generally. We get a Holter, which is a heart rhythm check for 1 to 2 days. We ask them about their symptoms. We have their surgical history. And this is a typo. So, right, we get a lot more information about these patients, but we don't have a great way to integrate all that information to say like, oh, this is the time, right, that we need to do something. Or this patient's going to do fine. Let's not mess with them at the moment.
Why do they do Holter for a couple of days? What is
Because if they have ventricular tachycardia, non-sustained ventricular tachycardia as a reason to do a pulmonary valve or list them for transplant. And some of them end up with ICDs if they have real ventricular, like sustained ventricular tachycardia. It's a risk factor for sudden death. So we put in an implantable cardioverter defibrillator so that we defibrillate them out of it. Which makes our MRIs a lot harder to do because there's a lot of metal artifact. But it's not super common, and it's less common than it used to be, but a lot of the older tetralogy patients have ICDs because of findings like that. And so my answer to Omer's question yesterday was like, what are the outstanding things? Is we don't really know what's happening to these patients in the rest of the time that they're alive, right? They come to the hospital, we get very sporadic data about them. But I think they were missing a whole bunch of data about them when they're living their life, right, regular outside the office. But the question is, what do we need to be measuring for them? And when is it relevant? So, right, wearable biosensors give us longitudinal data from their natural habitat, right? We can put it in different environments, like they're, playing sports or they're at home playing video games or whatever, right? What are they like then? And what does that mean? And obviously you guys know better than me that, right, improvements in battery life and miniaturization and connectivity, right, have been done recently. And then what kind of data, right, we obtain depends on the sensors. I don't need to tell you guys that, but really, and this is, there are all sorts of cool sensors coming out and we need to figure out what to do with them. So, right, what should we measure for a given patient, right? You would think that it depends a little bit on what's their physiology at that time. What do we think is clinically relevant? What could be actionable? I don't know, the Mayo Clinic guys, right, with their like age and gender prediction based on EKGs make me wonder whether like there's a lot more hidden data in these tests that we do that we didn't know how to interpret in the past. But I still think if you're kind of closer to the actual disease process that you're worried about, maybe that'll be more fruitful. And when should we measure that? And I'll talk about that in a little bit. And then obviously, how do we interpret the data we collect and make it meaningful or actionable? And that's kind of the same problem that we're having with some of these imaging biomarkers, right? Because you say, all right, well, the RV shape is different, but how do you control the shape, right? Like, what do you do differently to make the shape different? And then some challenges for wearable biomarkers in kids and those with congenital heart disease, right? We have limited device accuracy testing, right? Is it actually measuring heart rate or oxygen saturation correctly? And then there are some things where we don't even know what accuracy means, like SCG data, like I don't know what a normal is, right? And then wearability, right? How do we define what features are the most useful for the end user, right? So if we design if we take an adult device and we put it on a 1-month-old, is that going to work? Is it going to get in the way of the parents? And we'll talk about that. And then really our biggest problem is going to be validation, right? It, like for MRIs, like it took many years to talk about parametric mapping as being better than just subjective eyeballing the image. And it would be great to correlate it to hard outcomes, but you guys saw, right? Like only 5% of these patients are dying at age 40. So like, if we put a wearable on a 6-month-old baby and we say, oh, what are they going to be like at age 40? Like that's a hard study to run, right? So sometimes we have to think about what are the surrogate markers that we're going to use, right? Should we use exercise, stress, and peak VO2? Should we use cardiac MRI, RV volumes, and function, right? Like what is a reasonable surrogate marker to say, this data that we collected are meaningful? And that's the same with this event rate problem, right? Like if your pretest probability of some bad thing happening is quite low, the likelihood is you're going to get a lot more false positives than negatives, than true positives. Can't escape math, right? Or Bayes' theorem. So why do I even bother with any of this stuff, right? So this was one of the seminal, to me at least, ideas about studies about using kind of outpatient physiology monitoring. So this was the Champion trial. They stuck a pulmonary artery pressure sensor in patients who were getting discharged from the hospital, adults with heart failure. They're trying to predict and prevent hospital readmission. They put this CardioMEMS in. The intervention that they could do is change diuretic management. And they didn't do any fancy analysis, right? They got a daily reading of the pulmonary artery pressure, said, oh, should I change diuretics? And this led to a 34% reduction in heart failure admissions, readmissions, 37. That's huge, right? And there's a lot of money behind this because Medicare penalizes you if you have high readmission rates. So this is why a lot of these technologies are getting developed, because hospital systems think that it's worth it because they save money if their patients stay out of the hospital. But obviously, this is a physiologic monitor that's implantable, right? Can we do this non-invasively? So a couple years ago, this LINK-HF study came out where they used the VitalConnect sensor. This was a retrospective study where they used VitalConnectors collects continuous EKG, 3-axis accelerometry, skin impedance, skin temperature, activity and posture, and then they derived heart rate variability, arrhythmia burden, respiratory rate, gross activity, walking, sleep, and body tilt and body posture. And then basically what they said is, okay, if you're going to go home today from the hospital, let's say this is about as good as you can be. So they took the first couple of days of data and said, created some normal. Now, how they created that normal model is unclear, right? The paper doesn't say it. I'm sure it's proprietary to PhysIQ, which is the company that did the analytics. But they generated some normal model for this patient. And then they said, okay, how abnormal are you from your normal, right? Instead of the population level normal, they said for you, your normal is these 2 days. How different are you? And using that, 3 days. So in this study, their algorithm generated an alert a median of 6.5 days before heart failure hospitalization. And you can see that they found something meaningful, right? So this blue line is the freedom from heart failure hospitalization for everybody. But if you look at the people who had no alerts, right, they're generally pretty avoiding readmission pretty well. And if you look at the people who had an alert, right? So there's some meaningful difference between whatever their algorithm did. I wish I knew what it was, because that's what I need to do, but anyway. And then in infants with congenital heart disease, the Texas Children's Group published this paper where they used like the ICU grade data, right? Respiratory rate, oxygen saturation, EKG changes, ST segment elevation and stuff. And they generated this model based on these parameters to say real-time data processing predicts respiratory arrest 1 hour before it happens. So this brown line is their risk prediction. Once it got to some threshold, then this was the event that needed CPR or respiratory event. Now, like why the algorithm half an hour before says, oh, this kid's doing fine, I don't really understand, right? And they don't explain that in the paper. But they say, oh, look, this generated a model like this and they decided on a threshold which yielded a true positive rate of 45% and a false positive rate of 0.2%, right? And so the trade-off here is that if the true positive event means they're going to die, you're okay with some false positives as long as you get all the true positives, right? So it's worth being alarmed more rather than alarmed less. But what do you do about this? Okay, so it says like, your kid's going to do poorly, but it doesn't say why exactly they're going to do poorly. So it doesn't give you as much insight into like, what am I supposed to do differently for this patient? So so I think, right, by combining some of the stuff that we learned from adult heart failure and adult studies with the idea that we have high fidelity data can be meaningful in kids, now can we move to the realm where we're thinking about lower fidelity outpatient data for higher risk kids? So, we are trying to think about this in a few different ways, right? How about patients before and after a major intervention? Can wearables help us decide what changed about their physiology? In patients with defined periods of high risk physiology, including the ICU, can wearables give us extra data that help us manage patients? And then we'll talk very briefly about patients with slowly declining lifetime stuff like the Fontans and TETs. So you guys, so in terms of before and after intervention, you guys already saw this is how my prospective MRI study is set up. We do an MRI, hopefully within 6 months they get a valve, and then we do this follow-up MRI as the research scan. And we're gonna say, hey, did they have an appropriate response or not? And say, can we find new MRI metrics that predict this response?
So if you bring them in for the second MRI anyways, how old are they at this point? They're still
mostly teens to 20s. Mm-hmm.
So could you not do more of a comprehensive kind of phenotype of them, or I guess so things like VO2 max?
Yeah.
Like, is there not more that could be done besides just or did you have to kind of focus it for the grant basically just on MRI or?
Yeah, well, the K doesn't provide a lot of research money. It provides salary support. So we had to focus it on the MRI. So unfortunately, the clinical standard is not even to get a follow-up MRI. People just assume that it worked. And rarely do you do another exercise test. Like the use of exercise testing is pretty sporadic in this population. Most of the time we say, oh, their symptoms, are they doing okay or not?
Or is there another pharmacological challenge, or even like, I don't know, leg raise or anything to perturb the system?
Yeah, those are great ideas, but we don't generally do any of that stuff. But we should be, right? But if we already have enough trouble getting MRIs approved by insurance, like adding a bunch of extra tests for clinical use, we'd have to justify that a lot. Not that I don't think it would help, but right now the guidelines don't say that those are generally meaningful. So then
I just wonder if the response may not make a big impact on the baseline condition, but maybe it impacts their ability to up their,
Yeah, so we don't do stress MRIs in congenital heart disease, for instance, stress MRIs at Cleveland Clinic yet, but we did in Dallas. and but it wasn't routine. Stress, we tend to use stress MRI for like coronary anomalies where we're trying to see like, okay, when they're starting, or some kid comes in with syncope with exercise and you're pretty worried that did they have an arrhythmia or do they have a cardiomyopathy, like heart muscle disease? And so we tend to use exercise testing or stress testing in that situation. We could do dobutamine, right, which just raises your adrenergic response. We could do adenosine, which causes peripheral vasodilation. So yeah, I mean, there are studies, like limited studies of exercise testing in patients with tetralogy where you're stressing them out, but it's not part of the clinical workflow yet.
That could be an interesting way to pair up with like two birds with one stone. This
Yeah.
wearable pre-post perturbation.
Yeah, so this is what I'm trying to do, right? Yeah, no, so right now, what the next step of this project is from the wearable sense is we say, okay,
Yeah.
let's put a wearable sensor on when they come to clinic. Let's do a wearable sensor pre and post pulmonary valve replacement, immediate pre and post, and then we do another one at 1 year, right? And obviously this is just more like, oh yeah, this is the biointellisense thing. Yeah. I probably shouldn't use it without without blurring it out or something, right? But they're gonna hopefully be one of the companies that provide us with their, well, that I buy at decreased cost for this. So this one measures heart rate, position, step count with an accelerometer. And then probably by the time I actually start the study, they'll have an EKG in it. So like Vital Connect, the advantage of this one is that it lasts 30 days with no recharge. And so when we're trying to think about how do we drive adherence for patients, if they just have to stick it on and then forget about it, though it can be pretty itchy apparently. So it uses the same adhesive as the continuous glucose monitors, like the Dexcom monitors, but apparently it's still pretty itchy. So yeah, exactly, right? What Omar was saying is, can we, I'm trying to add on, right, a wearable component to the study that I'm already designing. We're already trying to get them in and say, and then that opens up a couple of different ways, right? So let's just talk about symptoms, for instance. Can we quantify that? A lot of people say they're fatigued and they feel better when they get a new valve. What does that translate to in their real world environment? Are they walking more? Are they sleeping better? Are they more active in general, right? And so if we don't measure it, we won't know. There have been very few follow-ups with, defined exercise stress testing and peak VO2 measurements. And then also, is there some discrepancy between these wearable metrics and the MRI, right? Like if the MRI looks better, but there's still a couch potato, did we really fix anything, right? Did we fix something meaningful for them? I don't know. And then, I'm thinking about starting with heart rate variability because at least in adult heart failure, the thought is that heart rate variability is an independent predictor of adverse events, but there's probably other data hidden inside these things that we might find meaningful, but it's unclear because this kind of data doesn't exist yet. So we're going to go get it.
Because they have, usually a lot of them may have pacemakers, ICDs,
Mhm.
they have bundle branch block, and all kinds of arrhythmias, and their sympathetic systems like
Revved to the max,
on,
right? Yeah.
exactly. So it's kind of like
Yeah.
always
I mean, right. I mean,
maybe help here.
well, that's what I'm actually curious about here to say, like, even in the immediate pre to post, do we see a change, right? So we're changing their physiology for sure. We put in a competent pulmonary valve, we relieve outflow obstruction or regurgitation. We should see some change in the physiology at that point, but we've never really measured it like this.
Yeah.
So that's the hope. But yeah, I mean, I have to start with something because we don't know what we're really going to see here. And so HRV is probably the place to start because at least there's some data in adults and we can think about it. But like what does step count change mean? I don't really know. There's not a normal step count for kids, right? We know that from the team in Canada, there's a team in British Columbia that's done a lot of Fitbit studies on congenital heart disease patients. And they're like, yeah, kids in Canada, they're less active in the winter. And I was like, I could have told you that without a Fitbit, right? But like, what does it mean, right? There's seasonal variation, there's, right. But I mean, we didn't know, it had not been shown before. I think they were probably trying to look at something a little more in depth than that. But what they were able to show at least was that kids in Canada are less active in the winter. So this is a study that I'm trying to do. We're trying to get VitalConnect and biointelligence and then actually compare how long people are able to keep it on. Because that way we can compare our wearability study, which I'll get to in a second, between the different devices as best that we can do that. We talked about periods of high risk. So they're like patients who are born with single ventricle heart disease have only one functional pumping chamber. And the typical one is called hypoplastic left heart, but there's a bunch of them that end up in this kind of general category. And generally about 1 week of age, we do this surgery called the Norwood, which is where we have to reconstruct their aorta. And it makes their functioning chamber pump to the body. And then we put in this surgical shunt that lets blood go from the arterial system to the pulmonary system, because they only have one pump, right? So we got to have it do both parts of the work. And then at about 3 to 6 months, we do this second surgery called the Glen, and we take down this shunt and we put in the SVC, the superior vena cava, as a passive blood flow to the lungs. And you can't do that early on because the pulmonary vascular resistance is too high, so the passive flow won't work very well. And in between these two periods is called the interstage, right? In between stage 1 and stage 2. And they have like still pretty high mortality in that 6-month period. Half of them get readmitted. It's a bunch of reinterventions. And so in this scenario, we're not talking about a low risk population, right? There are events that are happening to these people. And we are not very good at predicting these events because of the deaths, 75% of them are unexpected. About 23% happen at home and 33% in the emergency room. So like, even when parents figure out that something bad is happening, they often don't show up in time. And so in Dallas, because we served a large area, we would actually make these patients stay in Dallas. So even if they're like live in El Paso, we make them stay at the Ronald McDonald House in Dallas because we were so nervous about them that we didn't want them to be 8 hours away. And so, what do we do? Like, what kind of data do we get today, right? So right now we get weekly clinic visits, weekly or every other week echoes, daily weight, daily feeding log, daily pulse ox once a day. And because of this mixed circulation, where like all the blood that's going to both the body and the lungs comes together in the aorta, their expected saturations are 75 to 85%. That's what we want them to be. If there's too much, their sats are too high, that means too much blood is going to the lungs. If their sats are too low, that means too little blood is going to the lungs. So generally it's like the hospital plug-in one, and they use the finger wrap one. Yeah, so we give them DME, durable medical equipment, get them a pulse oximeter.
What's the main leading cause of death?
We don't know. Autopsy studies have not shown us what the leading cause of death is. There's a theory that it's an arrhythmia because giving digoxin, which is like an antiarrhythmic medication, seems to decrease the mortality in this time frame. But in other studies, the people who had a known history of arrhythmia and the kids who didn't have a known history of arrhythmia didn't have different death rates. So maybe, there's a one-time arrhythmia, but probably more likely to me is these are people whose, right, all the blood going to their body comes out the aorta and then some of it goes to the lung. So if the baby's crying, their pulmonary vascular resistance goes up. So you can see them turn blue when they cry because they get less blood to the body, or less blood to the lungs, more blood to the body. Or, if you tense up your muscles, you and I can change our systemic vascular resistance quite a bit just by tensing our muscles. But it doesn't matter because we have two pumps. So like you can overcome that, right? But if you have these parallel circulations, what that means is like, if you really increased SVR, these babies can just send all their blood to their lungs. Sats will be 90, but they'll still be gray, right? Because no blood going to their body. So I think it's a sudden change in vascular resistance, but we don't actually know. And that's one of the things that I hope to figure out, right? Because if we can look at patterns in the oxygen saturation, and right, so try and use oxygen saturation data and heart rate data and say, oh, there's a bad event that happened here. What happened differently in the last X hours? Perhaps we can figure out what is the leading cause, right? Because if it's a pulmonary vascular resistance problem, we'll probably see lower SATs. If it's a systemic vascular resistance problem, we'll see higher SATs. If it's a arrhythmia problem, we'll see high heart rates. So that's the hope, right? But again, and this is what the Texas Children's Group, this is what the Texas Children's Group did in the ICU, right? They used these kinds of data. But Texas Children's has a process where generally they keep these kids in the hospital the whole time, up till 6 months, or whenever they get their Glenn. Not most programs don't do that. It doesn't actually seem to improve your mortality in that time frame. So there's a lot of unpredictability here that we don't know. And so that's exactly what we need to figure out. And right, so SATs both too high and too low are bad. We already talked about some of this stuff. And actually in here, heart rate variability in the NICU predicts necrotizing enterocolitis and sepsis mortality. There's some devices that are on the market that you can plug in the NICU, and it tells you like a sepsis risk score out of the UVA group. And we already talked about the LINK-HF study. So I think there's very little work about this in the outpatient setting because the technology about accurate pulse oximeters has not been there. Now, are we there yet? I don't know. Right, there are no FDA cleared wearable pulse oxes for babies. The company I told you about at the beginning, I helped them get some data in Dallas to move in that direction, but it's a very finicky technology, right? It's not very motion sensitive. It doesn't do well with low perfusion, which these patients probably have by definition to some extent. So we're going to have to try it and see what we get.
And challenge to go back and mention that right? Pulse ox is an optical measurement technique through a wavelength.
And then, right, what are we trying to achieve, right? We want to reduce morbidity and mortality, reduce resource utilization, right? Like if we see that they're really okay, then great. We don't have to, we don't have to admit them. Better time, determine the timing of nectin intervention. This is a real problem, right? Parents do their 1 time a day SAT 68. We're like, that's too low. Come into the hospital. And then they come into the hospital, it's like 75 all the time. You're like, all right, well, you're fine. So they spend a couple of days and then they go home. What if we had continuous data at home? We could be like, this is actually what your SAT range is normally. It's not an acute change. You're actually doing okay, right? And these numeric cutoffs, specifically, 70 to or 75 to 85, probably not appropriate, right? We should pick the range for that patient, not the range for any patient. Well, I told you we send these parents home and we teach them all sorts of stuff to keep track of their babies. And then we're like, all right, see you later, right? Call us. And we have excellent nurses who are on call 24/7, but still not sufficient, right? And then we would love to let families live at their house and have the baby be in their real environment. So there's a lot of things that we could solve if we had the right technology and then the analytics behind that. Quickly, I don't know, we're running on time. This is a project that I'm going to do with Omer here, where we're going to try and look at low cardiac output syndrome. So actually 25 to 75% of patients after heart surgery experience low cardiac output syndrome, and 40% of those who develop low cardiac output syndrome die. It's a leading cause of death after surgery. And so the mechanism we think is that there's low cardiac output, there's low oxygen delivery that leads to low perfusion. Then they get lactic acidosis and kidney injury, and then we have to give them some meds to boost their system up. But if we can't fix all these things, they pass away. And the way that we measure low cardiac output in the ICU right now is we say, do they have kidney injury? Do they have lactic acidosis? Are they tachycardic? Or did we have to give them a lot of medications? So we're really looking at the process at the end stage, right? We're looking at the consequences of low cardiac output. We're not looking at cardiac output. And, in adults, you can put a swan, but the swans don't fit in kids. The finger-based PPG cardiac output measurements aren't super accurate. NIRS is only good at trending. There's a lot of limitations with the technologies that exist right now. So what we're trying with Omar is to say, okay, can we do seismocardiography? We're trying with this company to look at tissue perfusion as well. And can we catch these changes earlier in the process? And so with Omer, we looked at this in kids getting a cardiac MRI in congenital heart disease. We generated a model of stroke volume estimate that was reasonably accurate in the 50 or so patients. We used like 36 for training and 9 for testing, so 45 patients. And then this error bar is within what the FDA generally wants for clearance of the device, but I think we're still a ways away from that. And then this tissue oxygenation imaging actually looks at the oxygenation of the skin. And so one of the tests that we do when we are at the bedside is we feel their toes. Okay, are their toes cold? Or we squeeze out the blood and see how fast it comes back. But those are very subjective measurements. Can we actually look at oxygen delivery to the tissue non-invasively? And so, right, I talked about all the lagging indicators. We want to try and develop these as leading indicators where we're catching this downslope of cardiac output before they go into low cardiac output syndrome so that we can treat it. And then basically for these long-term ill patients, it's not always clear what we should be measuring and when. This is a challenging problem to solve. Should we measure it early when they're doing okay, but we don't know what to do with it? Should we measure it something late where now their liver and kidneys are shot, but we don't know what they're already too sick? It's a balance, right? And this is many years. So, and then we need to really understand how do we make wearables for kids that they're actually going to wear, right? What's important to them? I don't know. What's important to the parents? Is it battery life? Is it itchiness? Is it, that it's beeping at me for false alarms all the time? So as part of all of these studies that we're going to do, we're developing this survey to understand what are some of the human factors that go into, easy, convenient. The app was easy to use, right? Had too many false alarms. And then we're going to get adherence data and we're going to try and see what are the most important factors that drive adherence so that then your lab or others or companies can say, oh, we have quantitative data about the fact that it doesn't matter if it's 10% heavier, but if we get an extra 5 hours of battery life, that's a trade-off worth it to the people who are actually using the sensor. I've not found very much about that in the literature. Each company does its own secret testing, but it's not published and it's not compared between devices and it's definitely not for kids or babies, right? If you make a really bulky sensor and gets in the way of diaper changes, no parent's going to use it, right? I have a 2-year and a 4-year-old. I wouldn't use anything that gets in the way of diaper change, right? So you got to figure that stuff out. It's not been measured. So, and then obviously there's some stuff about how do we incorporate outpatient wearable data into the clinical workflow that's right outside the scope of this talk. And then, what if we can think about murmur detection, or we can track patent ductus arteriosus in the NICU, or, where we talk about wearable lactate sensors for cardiac output. There's lots of stuff that we can do. And then, right, the long-term goal is okay, there's a patient, we get some hospital data, we get some imaging data, we get some wearable data. How do we put that all together for each patient and know, okay, this is the time that we have to do this for this patient? And this is, I think, where we really need to head, is instead of doing one parameter at a time, we put it together in some holistic picture of a given patient. And then we need to get it to, to actually get to clinical implementation, right? So commercialize it, get out of this valley of death, and get it to patients, right? Get it to be effective and not just get stuck in academia. So if you want to talk about wearables with me for pediatrics, we're starting a work group through this International Society of Pediatric Innovation. And if you have other thoughts or questions, just email me. So thanks to my colleagues. Thanks, Omer, for inviting me, and Leanne, and this is great. And hoping that this will be the start of some more collaborations between our groups. So thanks so much.
Looks like regarding the first part of your talk, I know your work is mostly on biosensor, but on the treatment part, like you have a patient, you do a surgery, 5 years later, the patient is growing, so you do have surgery. Would it make sense to have adjustable valves?
Yep.
Would that help? Are they adjustable valves on the market?
So people are trying to make some that grow with the person, like they're trying grow. People are trying to make valves that have a scaffold inside that you can serially balloon. I think the problem with some of those is that in the babies, there's not a good, right? So if you make like a cylinder and the cylinder is long but narrow, and then you want it to grow in radius over time, then it needs to get shorter, right? But it's too long to fit in the baby as well, right? So like if you have a certain circumference that you want it to be adult size over time. So I think most of what I've read about, and that's not my expertise, but there are like companies out of that are trying to make valves that'll grow. And then make the valve scaffold that'll grow too, right? Like the valve annulus, because that can grow, you know, from 2 centimeters to 20 centimeters over the course of their life, right? So you want it to be, it needs to be very expandable over time. So I think most of the people are taking the approach to make a biomaterial that'll grow or get replaced with real valve tissue and stuff like that.
Thank you.
But that's a great question. And there's actually been workshops about like implantable valves that'll grow with babies that FDA sponsored and stuff like that. So.
I have a question that since we have some optics and specialists in the room, so we always think of pulse oximetry because of the fact that it's kind of this, I guess, proxy measure for how well we're kind of bringing in oxygen delivering tissues, right? Is there, I mean, if you kind of step back and think about the ways that the patient, let's say, in that stage process or time period, can move in or out of that band of operation, really, that you want. I mean, are there other indicators of, say, perfusion or other kind of biomarkers that might be in interstitial fluid or other sorts of, like pulse oximetry is hard, right? And kids, you have low perfusion, you have a high heart rate, you have probably limits on the amount of heating that you can deliver to the skin with the sensor, with the LED. I mean, so it's a very tough measure to get accurately anyways, like as Michael said. So, but then if you have kids who are at low perfusion kind of states, then it's even harder. So is there another measurement that we should be going after? I mean, MTOI is kind of one, I guess.
Yeah, so it's still optical, but it's, it's I'm hoping that will yield something at least in our low cardiac output area, and then we can move backwards, right? But I think, right, what are the, so I think the part of the reason that we've been stuck on pulse ox is because of the shunt, right? Like shunt thrombosis is a fatal problem for these patients, right? If this shunt thrombosis, right, if that gets clogged, then they're dead. They have no blood to the lungs, because that's the only source of pulmonary blood flow.
Right.
So we try and titer, right, the shunt size to what we guess will get them 1-to-1 blood, right? 1 part blood to the body, 1 part blood to the lungs. That's what you and I have. And we're trying to replicate that for these babies. And if you do the math with a normal cardiac output, that ends up being sat 75 to 85. Like 75, if you have a, AVO2 difference of 50, of 25, right, which is generally low cardiac output or normal cardiac output, then your mixed sat is 75, your venous sat is 50, and your arterial sat, your lungs are providing you 100% sat. So, right, that ignores various, it takes some assumptions into account, but that's why we target this range. Because it also tells us, in essence, how much blood is going to lung versus how much blood is going to the body. The math of oxygen delivery, and I can talk about that. So I think part of the reason we get stuck on that number as a way to measure it is because it tells us this ratio of blood to the lungs versus blood to the body. But that's not a biochemical marker of oxygen delivery, right? That's what we really care about, is the body tissue getting enough oxygen? So yeah, like continuous lactate. I don't know what that would mean. We know in ICU settings, high lactate is bad for you. That's been repeatedly proven because that's a reaction to low oxygen delivery to the tissue, right? They become anaerobic, you get lactic acidosis. But there are probably biochemical, right? If you had a skin patch that had microneedles and it was sampling the interstitial fluid for something, I don't know what that something is yet. And even the ICU stuff is like super crude, right? Like creatinine for kidney, like that's not the best, right? So
What about other physical changes? I mean, would you expect, for example, if someone's in hypoxia, in a situation like altitude, and there's hypoxia, like you get vasodilation, right?
Yeah.
Exchange more oxygen. Like, would you expect to see some, unusual increase in peripheral vasodilation? Like, is there some other? I'm
have to think about that.
Is there some other proxy marker?
Yeah.
That maybe can be detected together with pulse ox.
Yeah.
To give you the signature of maybe a kind of.
Yeah, I mean, perhaps. And, so the Kansas City group has been using an app where you can videotape the kid, like the baby, every week or something like that, or every day. And they qualitatively think that the videotape of the baby is the most important data that they're getting because they see, is the baby active, are they moving, are they behaving normally? And, it's that gestalt, like overall appearance of the baby, like, or do they seem happy or do they seem like they're sick? But, right, that's, so they're thinking about like, can we use AI to analyze the video and see, but like, maybe just movement, right? Is the baby moving around normally, right? Is that indicative of enough cardiac output? We get worried about vomiting. So if babies are vomiting, we think that that's because it's gut ischemia until proven otherwise. So we think, oh, is there enough perfusion to the gut? If not, we literally admit interstage babies for vomiting because we're worried that they're not getting enough blood to their gut. And so when they're eating, they're not digesting and it makes them throw up. So, I'm open to thinking about anything about, right, where the key thing that we're talking about is blood flow and oxygen delivery to all the end organs. This shunt thrombosis is a potential problem, but so are changes in SVR or PVR, right? But what is the time frame of that? How do you measure that continuously? We've never had a mechanism to be able to do that. So it would be great if we had something that told us more about how pulmonary vascular resistance or systemic vascular resistance changing over time. Like we measure those things in the cath lab, but we're not cathing them all the time, right? So, but yeah, I mean, I can imagine that there would be biochemical markers that would change if they're having poor tissue perfusion. I just don't know what they would be outside lactate and how we would measure it. But yeah, I mean, the SAT, I think we're stuck on SATs because it's something we can measure and it tells us something about blood distribution. But it's a very, it's not a great, Massimo claims they have like motion resistant and perfusion resistant pulse oxes, but I don't know how to validate those claims. So.
Previously, we did, it's probably possible to use the wearable device, the wearable device on a patient, or maybe for your monitor that.
Yeah.
But do you think that's probably necessary to truly understand what's happening?
Yeah, so probably not, right? We probably don't need wearable data for 40 years to know what's happening with the patient, but I don't know when in that 40 years is the best time to do it yet, right? Like, what we're trying to predict is when should we do the next intervention, and is it going to help them, right? And so I don't think that we have great predictors yet of even clinical predictors, right? Like, oh, what kind of surgery did they have, or how much did they weigh when they got their surgery, or and I think there's a lot of confounders in between the time that they, what were they like before the surgery, which surgeon did it, how exactly did they do the surgery, what size patch did they cut, right? Like this is all on the fly. The surgeon's like cut out pericardium and they put it in the, put it in the area and the shape that they think is going to work right. And and then I want to tell the parents like, oh, you're going to need a valve in 10 years, or you're going to need a valve in 30 years. I honestly don't know what to tell them. I say, hey, we're just going to keep watching you every time. And we'll see you every year, and we'll kind of see how this changes. Some babies need it at 5 years. Some wait till 45. Like, I don't, so it's probably not required to have the data for 40 straight years to understand what's happening with them. But I don't know what the sampling frequency needs to be for us to get meaningful insight out of that yet. So that's why we're trying to think about, like, where are some obvious changes, right? Like, there's obvious data to be had in oxygen saturation in this 6-month period. There's obvious data to have in the ICU in the first 24 hours because they're, something about them changes in that time frame. Before and after valve replacement. These like slow burn long-term patients, I don't know what to do with them yet. I don't know what we need to be measuring. And yeah, I mean, like the likelihood of them going from totally fine to dying on a given day is super low, right? So, for adult atrial fibrillation, now people are catching more hidden atrial fibrillation with their Apple Watches. Like that's been shown in a couple studies now. But does that mean that we weren't under-treating those people, or that our cutoff for a 24-hour measurement was actually too high, right? Like, are we over-treating the people who happen to have AFib on their 24 hours, but if you watch them for 2 weeks, their overall burden is lower, right? Like, I don't know the answer to that, because you're just thinking about, when did you get lucky and catch the signal in a thing that's sporadic? And so there's some debate now about like, it used to be like, oh, 3% of atrial fibrillation burden on a Holter means you should treat them. But like my dad had AFib recently, and then he got twice the dose of anticoagulation. So it's not a no risk problem, right? We were like freaked out. He's going to have knee surgery. We're like, all right, is he going to just like, do we have to delay it? Is he too anticoagulated? So it's not like any of the interventions we do have no side effects, right? Or can't go wrong. So I think the continuous sampling is going to give us a better idea about what's the real rate of some sporadic problem. But I don't know what the optimal sampling frequency is yet for any of these things that we talked about. But until we get some data and say, oh, well, this is meaningful and this is not, you can't back calculate that, right? You have to have all the data and say, oh, we only needed 10 minutes of data. And that's what I was saying way at the beginning, right? Is like, can we optimize what our sample signal acquisition timing and identification is? Once you have a whole bunch of data, you say, hey, like we don't need Q 1 minute oxygen saturation for the next 6 months. We can do it every 10 minutes or every hour, and that is still enough information. But until you have the every 1 minute data, and then you theoretically take out 9/10 of the data, you're not going to know. So.
Following up on that, and a lot of your discussion has been on measuring new things. Instead of that, is there use for measuring irregular things, pulse oximetry or something, but specifically for pediatric patients that you could do a follow-up for with a higher sampling frequency? Yeah, for sure. So I think, this ICU study is a great example, right? This is the stuff that we get every day anyway, right? Heart rate and oxygen saturation, respiratory rate, EKG, right? ST segment elevation. Like this is all stuff that's very standard that we apply in the ICU. But we didn't have great ways of putting them together into this risk model. So this is what like Texas Children's and this company called SickBay, that's what they're doing for these data. There was a prior company that called Etiometry that had created some physiologic model, and they were using the ICU data that are coming in from the electronic health record. So not waveform data, but like the numeric data out of that to generate this, it's FDA cleared, like
risk of low oxygen delivery score or something. It's called something like that. The problem with single ventricle kids is that right now their algorithms predicts a risk of SATs under mixed venous SAT under 40. But if your starting SAT is 75, then you're going to be under 40 a lot, right? Your mixed venous SAT is going to be under 40 a lot. And so they get a lot of false alarms for single ventricle kids. So they're working on the next version that says, oh, we're actually trying to predict the arterial to venous oxygen saturation difference as a marker of cardiac output. But again, that's an underlying model. Why don't we just try and find better ways to measure cardiac output instead of just saying, oh, we're generating an algorithm that predicts what the cardiac output is. So, but yeah, I mean, this stuff about like even getting the normal numbers that we get generally has not been a thing until like the last 5 years.
I remember reviewing their paper, by the way, I'd be very upset about the fact that somehow it went from highest possible risk index to 0.
Yeah, and then the baby had a bad event.
You look at the physiology and it's like the heart rate went higher, the SpO2 went lower. Like what?
Right, why is their algorithm saying that the baby's doing just fine here, right?
It looks like it's absolutely worse than it was before.
Yeah.
And I mean.
This is a paper in JACC. It's a JACC paper.
I looked it up on.
Yeah.
This is surprising.
But this is like, their company black box, like, oh, we generated this
That's why a
algorithm.
lot of this stuff is very hard to believe. I mean,
I think the model highly depends on the noise on the very top signal, because if you look at it, when it is noisy, the risk is very high, but at the middle, the noise is very low. That's why the model shows a very low risk.
I think you're right. There's also looks like a lag maybe, and when the risk goes up versus when the things are happening. But to say that SpO2 went down by that much within that window, and to not say that that's a high risk scenario, to say 0.
Yeah, right. Like if this is the trigger, right? Like the change from this is the heart rate, and this is I think the SAT is this green line, right? So the SAT went from here to here. It took 5 minutes or something to say, oh, from here now let's make the risk go from basically 0 to like this is bad news, right? So,
But you're absolutely right. I think it's just a high frequency variation on the heart rate, which is like if you had motion artifact also probably you would get that.
yeah, we didn't talk at all about artifact or noise suppression or in any of these wearables we have to deal with that stuff. But so
Well, I think probably we should call it.
yeah, sounds great.
Much. Thank you everybody for coming. Thank you for the talk.
Oh no, I'm excited to be here. So and I hope this is what you guys were looking for in this kind of talk. Okay.
Yeah.
Okay,
I don't
perfect.
know who attends online, but probably it's good they recorded it as well. And, I guess we can end it.
Okay. Where's my mouse?